Hi, everybody. It's a pleasure to be here. It's interesting to come back to your undergraduate alma mater and realize that no matter how often you come back, it still makes your heart really warm. So as I was thinking about this lecture today, I thought I would try to personalize it a little bit, and you'll see those throughout the talk. So we talk a lot about what we are in a very interesting place in AIDS, but I thought I'd start with first some background about some AIDS history. So going back to 1983, 1984, HIV was identified as the causative agent of a syndrome which was ultimately became known as acquired immune deficiency. And it began with this report from the CDC in June of 1981, where cases of some very strange diseases, pneumocystis pneumonia, which was seen only in cancer patients and the very elderly, and then another type of tumor called Kaposi sarcoma was being diagnosed in who were supposed to be young, healthy men. And the thing they had in common is they were all homosexual. Fast forward a relatively short period of time to 1984, and we had 4 publications defining HIV-1 as a lentivirus or retrovirus as the causative agent of AIDS. And it's these 4 papers. Over the next period of time, what we call is the age of discovery, or also a very dark period in the history of HIV/AIDS, AIDS was a death sentence, a very significant death sentence. And this information didn't change for years and years. And in 1986, when this publication came out, you can see that the probability of death from diagnosis with AIDS was within a year, and the probability of death at 5 years was 85%. So it was not a survivable disease. We were in a situation where we had a virus infection that was essentially a death sentence with no treatments. So I call this the early days and age of discovery. And to give you a sense of how fast time and history changes, I want to point out that everybody born after 1984 has lived in a world with AIDS. Everybody born essentially who's an undergraduate here today, born after 1994, has only known AIDS largely as a chronic manageable disease, because in 1994 and 1995, we had the advent of probably the single greatest success of biomedicine over the past several decades. And that is the development of antiretroviral therapy. But one of the hallmarks of this period of time in AIDS was the fear and stigma associated with HIV. And as you saw, here's the famous Ebola patient that came and was treated at NIH. And we have not had an outbreak of Ebola in the United States. What we've had is an outbreak of Fearbola. And the amount of time and energy talking about things like quarantine and shutting the borders is so reminiscent of what we were going through in the 1980s that many groups had to actually run ads like this. You cannot get AIDS from a drinking glass. You cannot get AIDS by shaking somebody's hand, and you cannot get AIDS from a doorknob. This was the type of ads we had to be running at that time because of the fear and stigma associated with HIV. You can substitute Ebola into any one of these and it would be equally accurate. So there's something about disease in the human condition that seems to engender fear and stigma, and it continues to today. Just in New York City and other places around the world, sex workers are arrested for having condoms. Now, here we have a method of preventing sexually transmitted diseases. Why are you arresting people for possessing condoms? Homosexuality is illegal in 79 countries, and the number is not decreasing. It's actually increasing. This is the problem, and this is the world we live in. So we must continue to fight against this kind of cultural barriers and against stigma. But over the 30 or 35 years since the discovery of HIV, we have had an amazing set of breakthroughs in the areas of research shown on the slide here. And as I said earlier, the single most important and effective area has been in the area of HIV treatment. And if you think about what we have today, is we have treatments, drugs targeted against all these places in the HIV viral life cycle. So the virus goes into the cell, it turns from, it goes through its replication process, but there's an inhibitor or a drug against almost every step in the virus. There's a block against entry. There's a block against the first production of the genetic material. There's a block against the integration of the virus into the genome. There's a block against maturation, and there's a block against release through the protease inhibitor. This is a profound set of drugs. They're all listed here on this slide. And through this list of drugs, we have been able to take HIV from a near-death sentence to essentially that an individual who is 20 years old, starting on antiretroviral therapy, assuming they have access to the Affordable Care Act and can get prescriptions, can, by all rights, have a relatively normal lifespan and a productive life, provided they adhere to these medications. So this is the world we live in and live in today. And so if you think about the time frame from 1981 to 1994, where all of this was accomplished, it is a profound amount of science and technology that has been developed. Moving forward, at the time, so here are two covers from different magazines. The Newsweek cover is from 1995, when the drugs were first licensed by the FDA and started to roll out. Does this define the end of AIDS? Well, it obviously didn't. And then with the work that the NIH supported in 2010 and 2011, we had End of AIDS redo on The Economist, that at the time, what we had been able to do is increase the number of people globally who are receiving antiretroviral therapy from a few 100,000 to 5 million, whereas in the UN AIDS report that was just released for World AIDS Day 2014, there's almost 14 million people around the globe receiving antiretroviral therapy. Please keep in mind that is roughly a third of all people who should be on therapy, but it is a fairly profound increase. So I'm going to spend my time talking a little bit about prevention and the importance of preventing HIV infections, because the best way to stay healthy is obviously to prevent infection, but ultimately a whole line of new research on curing HIV infection. This is our major areas of emphasis 2015 and beyond. Now some history on where we are with the global pandemic. To date, there have been approximately 78 to 80 million people infected with HIV around the world. Approximately 39 to 40 million people have died of HIV. There are currently about 35 million people living with HIVs, hence the number of approximately 35% or so. If you have people who should be on therapy, which are those who are living with HIV, have access to therapy. Approximately 1.5 million deaths in 2013 and 2.1 million new infections. Now, I have some curves that I think are interesting to unpack a little bit in terms of the global epidemic. You'll see that between 1990 and about 1995, 1996, there was a rapid increase in the number of infections. And then there was a degree of saturation within the epidemic. There wasn't anything that we were doing differently other than testing. And then over the time period from about 1997, 1998 on, there's been a decline in the number of new infections. The number of deaths peaked about 2004 and have been declining largely due to the rollout of antiretroviral therapy. But because there are still more new infections than deaths, you see in the curve of the number of people living with HIV, there continues to be an increase. Many people look at that and say that's bad news. I say it's good news, because the more people that are living with HIV, there are fewer deaths, and that still remains a goal. Domestically, in the United States, we're at about 1.1 million people living with HIV. And the sad news is approximately 16% are still unaware that they harbor the virus. That number has improved fairly significantly from approximately 75%, 25% a couple of years ago. There's been a large effort in testing. In the past year, approximately 630 or so million Americans died of AIDS. And every year, 50,000 new people get infected with HIV. This number has been stubborn and constant for about the last 2 decades. What has changed in this number are the people who are becoming infected. The single largest group that are contributing new infections each year remain men who have sex with men, but it is significantly impacting black MSM, and particularly very young black MSM, to a point where it is a significant health crisis in the United States in the African American community. This remains a major, major challenge that we face domestically rolling forward. And youth are heavily impacted in this epidemic still today. So I propose, and this is a given fact, that the foundation of all HIV prevention is first knowledge. And the knowledge you need to obtain is your HIV status. Have you been tested for HIV is a question. And we all need to answer that question for ourselves. And if you are HIV, if you do receive an HIV test, there are 2 answers to that. You are either HIV negative or you are HIV positive. If you're HIV positive, there's places that you need to get to in terms of the health center, Whitman Walker, that will get you into a care continuum and get you the counseling and the treatment that you need in order to stay healthy. If you're HIV negative, you need to enter the prevention continuum. Now, we are on the campus of an amazing university. The University of Maryland is one of the most forward-thinking places in the country when it comes to health services, and particularly sexual health services. They have a staff member over there named Jenna Beckwith, who, if you haven't had the chance to meet her, I encourage you to do so. Her heart and soul is in helping the students at this university. Today, every 3rd Thursday of the month, is free HIV testing day across the street at the health center. It started at 10:30, it ends at 2:30. So if you get there, if you leave now, you may be able to get your test, but I encourage you to stay and hear the whole talk. If you feel you need an HIV test, you can walk in and get tested on demand. If you want a rapid test, if you want to know in an hour, it'll cost you $25 on your health insurance. Depending on why you're there, it may be very well worth it. As Jenna says, she watches the students coming in for testing, and if there's somebody that's repeat testing a lot, she thinks this is somebody who needs counseling, and she offers individualized counseling. If I were a student here, I'd be in her office. I think she is about the most approachable, friendly individual I've met in a very long time. Additionally, she set up a program. There are 26 trained peer educators on campus, and they make the rounds to fraternities and sororities and social organizations talking about STD, sexually transmitted disease, and HIV prevention. The good news about being a trained peer educator is you get 3 college credits for it. So they have set this up in a way that is ideal. Last semester, the health center distributed 86,000 male and female condoms on the campus, which is pretty profound. Not only do we have these great prevention services on demand, but you have a very forward-looking health plan. It's really interesting that we are here in Maryland, and our student health insurance covers transgender care. How fantastic is that? Additionally, the university has an incredibly strong relationship with the Whitman Walker Clinic downtown, and physicians come out and see students all the time. I'm going to talk a little bit later about pre- and post-exposure prophylaxis. It's also covered within your health insurance, but through specialty pharmacy. So we live and work in a very rarefied place. We also have been nationally recognized. In what other sport is Maryland ranked number 3? here we have the sexual health report from Trojan that ranks the top universities in terms of sexual health and the services available to you, the students. Maryland is number 3. Notice you're number 1 in the Big Ten, and if you were still in the ACC, you would still be number 1. Apparently a year or two ago we were number 2, but Oregon State has jumped up because they have really put time and energy into this. This is the kind of independent validation as a university you absolutely want to see for a program like sexual health services. So what Jenna and the team do is they offer a prevention toolbox where you, as a student, have your needs. Are you concerned about getting pregnant? Are you concerned about sexually transmitted diseases? Are you truly concerned about AIDS? But the entire prevention toolkit is designed to make your experience here at Maryland as complete as possible by eliminating worries in this aspect of your life. And then a worry-free student will be a better student, will learn better and excel better. And as you think about a vision of how to make a complete student experience, that is an ideal situation, that your health has such a profound impact on your education. That's what you want, is this kind of openness. So all these types of services are available. It makes the full TERP prevention toolkit, and those are available across the street at the health center. Now, let's spend a minute or two talking about what I do in my daily basis, and that is figure out how to develop new strategies to prevent HIV and ultimately to cure HIV. And I'm going to break that down and spend some time talking about the vaccine research, because ultimately the best tool to prevent any infectious disease is a safe, effective, and durable vaccine. Now, we had the good fortune at NIH to be involved in a study that was run by us and the U.S. military HIV research program, and the results came out in 2009. It was a trial that was done in Thailand called RV144, and it showed for the first time ever a signal that a vaccine was possible. It was a very weak signal, and so what we have spent the time from 2009 to now working on is understanding first what the source of the positive signal was, so we could make a testable hypothesis going forward as to what to change as we try to improve the vaccine. And so what we have done, we call that the RV144 approach. What are we going to do to further evaluate a vaccine? Additionally, other research progress has been made in terms of the isolation and detection of antibodies that are incredibly powerful, that can block HIV, and we're doing some structure-based design, and I'll touch briefly on that too. So first about RV144. So this is the bad guy. This is the surface protein of HIV in its 3-dimensional structure. It looks very benign, but what it does is it attaches to the surface of a cell and brings the virus in. So what you want are antibodies or other cellular proteins, other human proteins, that would coat the surface of this molecule and prevent the interaction of this protein with human cells. And what we have been able to show through analyzing the samples from RV144, the samples from the vaccinees, that their serum, when they associated with protection, had an antibody that attached to a portion of the upper face of the protein. Now, can we then reproducibly improve this response? Can we increase the strength, the breadth, and the durability of that response? And we have a number of options and opportunities to pursue how that could be done. We are starting our clinical trial in South Africa in approximately 6 weeks to start the process of evaluating this. That will start as what we call a phase 1, a first-in-human study with our new improved vaccines, headed toward phase 2 and phase 3, and ultimately, hopefully, licensure by 2017 or 2018. Those dates will be here before you know it. I know that sounds a long way away, but they'll be here quickly. So a large amount of work has gone into this, and we're about ready to truly launch something truly profound. The other area that has really received a lot of attention are new antibodies that bind to all those little dots on the surface of the HIV envelope protein. When those antibodies are purified and they're used, they have a profound effect, almost as profound as the antivirals I was talking about earlier. However, because they recognize in a very precise way, a protein has a very precise structure. It then will recognize a very precise structure on the envelope. Can we take that information about the shape of the envelope, figure out how to present it to the immune system in an uninfected person, and reproducibly trigger the production of that antibody in the vast majority of people that would receive that vaccine? So the design of this, if I had an antibody that bound my knuckle, can I take my knuckle and use it as an immunogen? And can I then trigger anti-knuckle antibody in everybody who receives this vaccine? That's the path that we're on here, and progress is also being made on this front. So I'm very confident that we will have answers to whether either or both of these work before the end of this decade. Notice I didn't say we'd have a vaccine. So then ultimately what we have is a situation where we'll have all the best of the combination HIV prevention and an HIV vaccine, which will really give us the tools globally to really roll out and implement at a level where we can really reduce the number of new infections. And what we mean by getting to zero is having the number of deaths equal the number of infections. So then we essentially flatline the epidemic and begin to start bending the curve in a downward trajectory. Because the fewer infections we obtain, there will always be death. But if we can get the number of new infections as close to zero as possible, it will then have a profound effect. And as therapy gets better, we will also continue to reduce the number of deaths. Now let's spend a moment talking about why we would ever think we could cure HIV. So we're in a situation now where I think we need to first define what we mean by cure. So in any disease, whether we're talking about, and you have a wonderful cancer lecture this afternoon at 5 o'clock, and I really wish I could stay and hear that speaker, because he has some very profound, new, outstanding ideas for how to tackle cancer, and it's always good when Terps can talk to Terps. So the definition of a cure of any disease is permanent remission following the cessation of therapy. So in cancer, we don't talk about cure, we talk about sustained remission and measure that at 5-year intervals. In HIV, we have not had a lot of these, so we are also need to consider this in the context of remission. But HIV is different than other infectious diseases. Many infectious diseases, the flu, which we vaccinate for, strep throat, you have an infectious disease, you eradicate the microbe, and you're healed, you're cured. And we don't think of that as a big deal, but HIV is different. And in some ways, HIV is like a cancer, and I'll explain why. And as with cancers, we have always measured the time of relapse as an important surrogate for cure. Here's the problem with HIV. People can be treated with the antiretrovirals for years, even a decade, and if they stop therapy, the virus rebounds. Why does the virus rebound? The virus rebounds because HIV has the ability, in a very nefarious way, to essentially become latent. It goes inside if you're immune, being at Maryland, you have to use a sports analogy. So the quarterback of the immune system is a cell called the CD4 cell. It's a helper cell. It's designed to direct all the immune responses to the right place at the right time. But when that cell activates and gets ready to go, it sets up the perfect Purina virus chow for HIV. The virus gets in, grows in that cell, stimulates further growth of that cell, and ultimately kills 99.9% of the infected CD4 positive lymphocytes. However, there's a fraction of which do something else that's essential for memory. one of the critical parts about your immunity is the ability to recognize when you have seen a pathogen before and respond rapidly upon reinfection. That's called memory. Memory involves the process of taking the activated immune system. I'm all geared up, I'm fighting. Now it's time to park the fire truck back in the station, go to rest, and wait for the alarm bell to go off again. What HIV does, sort of like the monster in Alien, tucks itself inside the ship and goes to sleep until it comes back to Earth. So here we are with a resting memory T cell, which is primed to find the new disease that's coming in, or the disease is back again. And you probably can't see it, but there's a little red line on there that indicates that resting memory T cell is carrying one copy of the HIV genome. 1 in a million resting memory T cells has this. And that cell lives for decades and is quiescent and sits in the body. So when you stop therapy, those cells normally cycle and will activate and divide, and one will activate and set off this explosion of HIV replication. So this is our challenge, is to find that cell and eradicate it. So why would we even think that's possible? Well, think about what the one answer is, think about what we've done in cancer. Cancer has always been about minimum residual disease. That's the term of art for when you treat somebody and they go into remission. Can you push that minimum residual disease as close to zero as possible and sustain that level of remission? That's what we're about. And so in some ways, the beauty of medicine is that your experience with one disease can often be applicable in another. And here's an example of where we can learn from the oncologists. Additionally, if you think about what we need to do, we're currently spending billions and billions of dollars every year to sustain 13 to 15 million on antiretroviral therapy. As I said earlier, 35 million people globally need to have access to antiretroviral therapy. It may not be economically or logistically feasible, particularly given the country's own abilities to, not our country, but the places where HIV is most prevalent, to provide this level of care and treatment to their populations. Some countries are really great at this. South Africa plans to spend $5 billion of their own resources next year in terms of treating their population. That's the country that has one of the highest prevalence of HIV. There's the other challenge with these drugs, as you saw, if you stop therapy, what happens? You rebound, is you must adhere. Adherence is essential. You must take your pills daily. There's pill fatigue. People have to take, you start therapy, you have to stay on this medication for the rest of your life. That is a significant challenge. I can't even remember to take a vitamin every day, much less have to take medication like that. Additionally, over the course of a lifetime, as safe and effective as these drugs are, there is the chance for emergence of drug resistance, and anything you take that frequently will have cumulative toxicities. So just something to keep in mind. So as we think about what we want to do as we move toward a cure, is can we eradicate it, the virus, from the body, like what we can do with cancer? Or can we induce the rest of the immune system to step up and fight HIV and create essentially disease control? And what we call that would be we call that sustained virologic remission. So basically immunize and really stimulate the immune system so that it fights back against the virus from within. So the strategies we consider are things like flushing out the virus. Can we take that latent cell and find the systems that could take that resting memory T cell, tickle it, genetically speaking, make it express HIV, so that then the immune system could suddenly see that cell as being HIV infected and kill it? Can we take a lesson similar to what the speaker at 5 o'clock is going to talk about? He talked about using antibodies to deliver drugs to specific cells. Can we essentially create an immunotoxic therapy that would be directed at that reservoir. So as you hear the lectures today, think about the linkages we have in science, that what we learn in cancer from the speaker, from Clay at 5 o'clock, is directly applicable to what I'm talking about today, and vice versa. So that's the great thing about science, is no matter what you learn, it will always be applicable at some point in your career. And so don't ever ask the question, why do I have to learn it, and why is this on the test? Because it will come back to get you. Gene therapy is another area. So I don't know if many of you are aware, but there's a whole population of Northern Europeans that are carrying a genetic mutation called Delta 32 CCR5. And if you're homozygous for this mutation, you are genetically resistant to HIV. Now, many of you are sitting there scratching your heads about how would that have ever gotten to the population? And that's an interesting question. And the answer to the question is plague. Back in the medieval times, plague selected, it was such a strong genetic selection, it selected for people that lacked that gene because they were resistant to plague. And it has carried through Northern Europeans ever since the Middle Ages. So what we can do is use gene therapy to engineer cells that are genetically resistant to HIV and then repopulate those cells into the human body. And there's a fair amount of experiments going on, mainly in cancer patients with HIV, where this kind of gene therapy linked to stem cell transplant is ongoing. So about a year ago, at one point we thought we had 4 people cured of HIV. At least they were in remission. We had Timothy Brown, who was the first person who was reported cured. It was published in that very important journal, the New York Times and the Wall Street Journal, before it ever appeared in the press. Timothy, as a patient, had one of the most aggressive forms of leukemia imaginable, a disease called AML. And he survived AML once and had his AIDS cured, his HIV cured. To make matters worse, his AIDS didn't come back, his leukemia came back. And he had to go through a second round of bone marrow transplant and almost died from the bone marrow transplant, but is now essentially HIV-free and leukemia-free. We had 2 patients that also had forms of lymphoma that were treated in Boston that looked like they were cured, and then we had the famous Mississippi child that you've all probably heard about that essentially was treated at birth with antiretroviral therapy and appeared cured. However, both the Boston patients and the baby have subsequently rebounded, so we have an N of 1 of who's been cured. So this is a very tall scientific challenge that we are seeking to tackle. So as I get ready to close and answer questions from all of you, I think we need to sort of imagine what a cure would look like. Just like we can imagine what a vaccine would look like. A vaccine looks like, ideally, a single shot that would provide you protection from HIV acquisition for a reasonably long period of time, several years, 5 to 10 years, similar to like what we would have with a polio vaccine or a smallpox vaccine. All these diseases have moved toward eradication. The flu vaccine we must take every year because of the antigenic change in flu. But ideally, as we think about a cure, what we would want is something simple, because essentially therapy is pretty easy. So in medicine, you first do no harm. And so what you'd want is something that was simple, and you also want something that's safe, and at least as safe as current therapy. And ultimately, it has to be scalable to be useful to the millions of people around the world. Now, what can you do as students, as faculty, that can help us end AIDS? Well, I think there's 2 levels that answer that question. First, at the individual level, particularly students, get across the street and get yourself an HIV test. Know your status and be honest about it. Ask the question of your partner, have you been tested? Make sure that your partners have been tested. And above all, keep yourself safe. Protect yourself. You are who you are. You need to take care of yourself. Nobody else is going to. But if you do engage in risky behaviors, take precautions. Condoms are available. Use them correctly and consistently. At the same time, there are other options in addition to condoms. There's pre- and post-exposure prophylaxis, and if you want to know more about that, I'll answer questions during the Q&A session. But as a member of society, you also must continue to fight stigma and homophobia and support each other, because we're all in this together. As long as there's stigma, as long as there's homophobia, there will be HIV. It's a fact. And we all need to do something to break that down. Volunteer. Consider becoming a SHARE peer educator at the health center. Spend time getting to know the problem and making a contribution. But interestingly, you can also have fun. World AIDS Day is December 1st. Here at the University of Maryland, last year, they had the very first Condom Couture fashion show. So yes, he's from the swim team, and that was one of the teams that entered costumes into the fashion show. This year, there's Condom Couture again, Condom Couture 2014. Again, the advantage of participating in this, either as an organization or as an individual, is the proceeds go to Whitman Walker. And so it is about AIDS. It's also about having fun and enjoying who you are. And if you're not a Terp, you don't know how to do that. I mean, this university specializes in playing hard and working hard, but working hard first and being the best it can be. So with that, I'll close and thank all my colleagues and friends who have invited me back time and time to speak at the University of Maryland. And I'll be more than happy to take questions. Thank you.
There was a medicine that I had heard of. It was Tetroxide, which has been, there's a patent that was filed for it in the early 90s, and the research kind of got dropped. And I thought that was mysterious. I don't know if it's related to high toxicity, or have you heard of such medicine?
I actually know the medicine very well. I've actually studied it because the part of the Division of AIDS that I was responsible for evaluated therapies preclinically. Going back in history, silver was one of the magic bullets that was used to treat STIs back in the day. So essentially, it's a retread of the anti-syphilis and anti-gonorrhea medicines. If you think about that, so you think about disease like gonorrhea or syphilis, it exists in the urethra, and so everything is exposed. If you think about treating the whole body with something like silver, it's kind of difficult. So the toxicities and the non-specificity of that compound was its death knell.
But it did have some varied success, correct?
For treating lesions on the skin or on a mucosal surface, it's quite good, but not in terms of treating any disease that's systemic.
Thank you.
So for some viruses such as dengue, antibodies don't help, and sometimes they can actually hurt. Is there any concern that you might have antibody-dependent enhancement with some of the antibiotic therapeutics you're
That's a really great question. So dengue, chikungunya, many of these other envelope viruses are associated with problems. It's not the first infection that gets you, it's the second one, because you've not made enough antibody to be protected, and just enough to make your disease worse. With HIV, we've actually looked very carefully at this, and there's no evidence in any of the vaccine trials that we've ever done of antibody enhancement. What we have seen, which is somewhat worse, is actually a response against the vector that causes CD4 activation that causes an increased susceptibility to infection. We did a trial called the STEP trial using an adeno vector that actually caused this problem. The antibodies themselves, we haven't had this problem. And the strength of the new antibodies are such that we have not seen that in non-human primate studies or in any use. Can you use the microphone so I can hear?
So you talked about outreach that's being done at the university, but what about public health outreach in MSM and in African American communities? Do you think that enough of that is being done, and whether that would play a significant role in the cure of HIV/AIDS?
That's a great question, too. Again, I think that we have to look at the country as a whole. And there are what we call hotspots where the epidemic is quite potent and strong. And I think Washington, D.C., I mean, about 5 or 6 years ago, there was a publication that came out called the Appleseed Report that showed the disease in Washington was as bad as in many African countries, and the incidence was through the roof. And those of us in positions able to do something about it have made a commitment to work with the Public Health Department in Washington. And essentially, we have taken the city and turned it around. We've cut the incidence significantly, and it's through the kinds of combination of clinical trials, outreach, and the work that the health department in DC has done, and they've done a very profound job of it. PG County does a really good job, Baltimore City. Maryland in general is quite good. When you get south, and you get into the rural South, you really have this problem. And at the same time, there are places in the country where there just hasn't been an uptake of the message. And there's still a fair amount of fear and stigma and denial about the disease and how it spread. So there's never too much of that, but there needs to be a continued dialogue. And we saw a great poster today on cancer outreach through the churches. And I think that there's a place, particularly in the African American community, for the churches to step up and do more in this area. And if we can get sort of health ministries going that can then first tackle diseases like cancer and diabetes and heart disease, and then make HIV part of that conversation, we're going to do more to normalize HIV and make it more accessible for people to talk about.
So given an antibody against the envelope protein, do you think that anti-maturation inhibitors could have an adjuvant effect by basically making the envelope stick on the infected cells and then having the antibodies attack the infected cells?
I think it's possible that a maturation inhibitor could have that kind of beneficial effect. I think also other entry inhibitors would work equally well. So you can hit the virus at the front and the back end of the life cycle plus antibodies, and I think you'd have a good cocktail. Yeah.
So, is this thing working?
Yes.
Okay, so about 2 years back, I had read a paper that mentioned a drug that is basically designed to cause latent HIV to become active in pretty much all cells where it was present, and that had been used to from what I remember, successfully treat it in a few cases. Do you know anything about that case, and is it connected to what
it is exactly what I was talking about. So those reports are on drugs that are called HDAC inhibitors. They're histone deacetylase. So if you think about the genome that we all carry in our cells, there are all these other proteins associated with the DNA that signal this segment of DNA is on or this segment of DNA is off. And there's a protein that's essential for the shape of our DNA in cells. There's proteins called histones. And those can be modified in different ways. And when you acetylate those histones, meaning you modify them chemically, it shuts down that DNA. So this compound, histone deacetylase, activates those genes and turns on gene expression. That's a strategy. They're called HDAC is the short-term acronym for that. That works reasonably well in cell culture. When you put it in the body, you get the increase, a small increase, but it's not enough to flush the full reservoir. So that's going to have to be combined with other drugs. So that is an avenue of research that's ongoing. Well, if there are no further questions, I really thank you for your attention and your questions.